All right, let's just jump right into this explainer. Today, we're basically stepping into the shoes of high-stakes medical detectives to examine what is, quite frankly, a true anatomical ticking time bomb, acute appendicitis. We hear about it all the time, right? But the actual underlying mechanisms and the crazy diagnostic puzzle it presents to doctors are absolutely fascinating. Think about this number for a second, 7 to 9%. That represents your lifetime risk of facing this exact surgical emergency. It's actually the most common cause of peritonitis, and it accounts for up to 80% of acute abdominal surgeries. So understanding the clues we're about to uncover isn't just some dry academic exercise. It's the kind of knowledge that could literally save your life or the life of someone you love. To decode this medical mystery, we need to follow the clues from basic anatomy all the way to the operating table. Our clinical roadmap today covers anatomy of a time bomb, mechanism of inflammation, clinical picture and symptoms, modern diagnostic methods, differential diagnosis, and finally, surgical treatment strategies. Let's kick things off with Section 1, Anatomy of a Time Bomb. Okay, let's look at our prime suspect. Normally, this little worm-like appendage hanging off the cecum measures just 7 to 9 centimeters long. It seems totally harmless. But here's the thing. It isn't just a useless vestigial tube like people used to think. It's actually often called the intestinal tonsil because its wall is just packed with a continuous layer of lymphoid tissue follicles. But it has a fatal structural flaw. It's supplied by the appendicular artery, which is a terminal-type vessel. That means there's literally zero backup blood supply. So if pressure builds up inside, the blood flow just stops, making the whole organ incredibly prone to rapid ischemic necrosis and thrombosis. And honestly, the appendix is a total master of disguise. Sure, it usually sits in the lower right pelvis, but its shifting location creates this polymorphic clinical picture that can confuse even the most seasoned doctors. In about 15 to 20% of cases, it hides retrocecally behind the cecum, which totally mimics a kidney issue. Sometimes, due to incomplete intestinal rotation during development, it sits way up high under the liver, perfectly simulating gallbladder disease or acute cholecystitis. And get this, in really rare cases of total organ reversal, situs inversus, it's actually on the left side. Moving right along to Section 2, Mechanism of Inflammation. So how does this quiet little organ suddenly go rogue and turn into a deadly threat? Well, while there are infectious, vascular, and even endocrine theories out there, the leading consensus points to a mechanical block that basically turns the appendix into a literal pressure cooker. Step 1. The narrow opening gets blocked. This is often by fecal stones in about 35% of cases or by swollen lymphoid tissue. Step 2. The appendix just keeps secreting mucus into this now closed pipe. The pressure rapidly spikes way past 65 centimeters of water. Step 3. This immense crushing pressure chokes off the veins and lymphatics, killing the blood supply and causing severe ischemia. And then, Step 4, with the tissue dying, local bacteria like E. coli swarm in, causing rapid total destruction. And if you want to see exactly how fast things go wrong, Kolesov's 1972 classification perfectly illustrates the ticking clock of this disease. It escalates from brief, relatively harmless appendicular colic to a simple catarrhal edema. But if that clock isn't stopped right then and there, it rapidly progresses into the terrifying destructive phases, gangrene and perforation, which ultimately leads to catastrophic complications like peritonitis or sepsis. Now let's talk about the physical clues in Section 3, Clinical picture and symptoms. So what exactly does this look like in a patient? The onset is usually incredibly sudden, very often striking out of nowhere in the evening or nighttime hours, and it evolves in a highly specific way. The most fascinating clue here is pathognomonic, meaning it's a dead giveaway. It's called kosher sign, the hallmark migration of pain. It always starts as this vague, dull, visceral ache in the upper stomach or right around the belly button. You'd probably just think, oh, I ate something bad. But after 2 to 6 hours, as the inflammation angrily spreads to the parietal peritoneum, the pain violently shifts. It locks right into the right iliac region as a sharp, localized somatic pain. Once that pain locks in, doctors look for Dolicho's triad: local pain, severe muscle tension guarding the area, and skin hyperesthesia, which just means extreme skin sensitivity. You'll also often see reflex vomiting, but here is the crucial detail. That vomiting only happens after the pain starts, never before. Toss in a complete sudden loss of appetite, known as Savitsky's sign, and the picture is becoming really clear. Now, to confirm things at the bedside, doctors use what I love to call physical cheat codes. These aren't just dry textbook facts. They are ingenious, author-specific maneuvers designed to outsmart the hiding appendix. You've got the Shchetkin-Blumberg sign, testing for rebound tenderness when you quickly pull your hand away. Rovsing sign, where pressing on the left side of the colon pushes gas backward to stretch the inflamed right side. There's Sitkovsky's maneuver, where simply having the patient lie on their left side pulls the inflamed organ and spikes the pain. We even have Razdovsky's test, where light percussion, just tapping on the abdomen, causes a literal shockwave of pain over the appendix. Let's look at how we confirm all this in Section 4, Modern Diagnostic Methods. Of course, when the physical hands of the doctor aren't quite enough, modern medical detectives bring in the high-tech imaging. In the imaging showdown, ultrasound is a fantastic first-line defense. It's fast, zero radiation, and looks for an appendix swollen over 6 to 7 millimeters with a rigid target sign. But the undisputed gold standard for adults? That's the CT scan with contrast. It offers up to 90% accuracy and perfectly spots those sneaky, atypical locations we talked about earlier. We pair this with lab clues too. If you see a C-reactive protein level over 10 milligrams per liter, combined with a white blood cell count over 10 times 10 to the ninth, you've got a 95% probability that the appendix is your culprit. From there, surgeons actually quantify their suspicion into mathematical certainty using scoring systems like the Alvarado score, or the even more precise AIR score. By tallying points for things like migrating pain, fever, and lab results, they make a totally objective call. If a patient hits 9 to 10 points on this scale, there's no waiting around. They are taking an emergency trip to the operating room. But we can't rush in blindly. That brings us to Section 5, Differential Diagnosis. Every good detective knows that in a complex mystery, you absolutely must rule out the imposters trying to frame your prime suspect. So many conditions perfectly mimic appendicitis. In the GI tract, a perforated ulcer or Meckel's diverticulitis look remarkably similar. In urology, a kidney stone can cause severe right-sided pain, though you usually look for it to radiate to the groin. And this is especially crucial for women of childbearing age. Gynecological emergencies like an ectopic pregnancy or ruptured ovarian cyst must be definitively ruled out. Sometimes that even necessitates a diagnostic laparoscopy just to be absolutely certain we have the right suspect before proceeding. Finally, let's talk about how we fix it in Section 6, Surgical Treatment Strategies. Once the imposter is ruled out and the appendix is convicted, we move to the final phase where we finally stop the clock. This always starts with a preoperative dose of cephalosporin antibiotics. The definitive cure is surgery under general anesthesia. Today, the laparoscopic appendectomy is the gold standard. They use tiny cameras, get a full view of the abdomen, and patients bounce back incredibly fast. But if there is severe scarring or the patient's hemodynamics are unstable, surgeons will pivot right back to the traditional open appendectomy, using that classic McBurney incision in the lower right abdomen. But wait, here is a shocking medical plot twist. If the body has managed to wall off the burst appendix with a dense mass of tissue known as an infiltrate, rushing in to cut it out right away is actually strictly forbidden. Doing so could severely damage the intestines. Instead, they use strict conservative treatment. The patient is hit with heavy antibiotics for 2 to 4 months until the mass dissolves, and only then is the appendix removed. Similarly, if an abscess has formed, surgeons will just drain the pus and leave the appendix exactly where it is for the time being. So, we've tracked this killer from its anatomical hiding spots all the way to the operating table. But considering that 7 to 9% lifetime risk, I want to leave you with this. If that dull ache around your belly button suddenly started creeping down to your lower right side tonight, would you recognize the ticking clock of Kocher's migrating pain in time to save yourself? Rapid diagnosis prevents severe complications, and the human body is just full of these amazing, terrifying mysteries. Knowing how to read the clues really does make all the difference. Thanks for joining me on this explainer, and keep questioning how everything works.